What we're going to talk about is our complex care indicators for the use of antipsychotics. The complex care indicators basically refer to an indicator of less usual practice, because this is a treatment to be used after more evidence-based treatments have been utilized, after ostensibly less risky or more efficacious treatments have been utilized. And so it's an indicator of less usual practice. It's not a bad practice. It's not a practice that's prescribed, but it's an indicator of less usual practice because of those reasons. And again, it's important to note that it's not a practice that's contraindicated, but just warrants additional attention. Have you tried the more usual things first? Have you tried treatments that have more evidence base to support the utility first? And if you have you tried it adequately, if you will? And that's what a complex care indicator is. And we're going to focus on different indicators, complex care indicators, with regard to antipsychotic utilization, with a focus on antipsychotic polypharmacy. In terms of conflicts of interest, no relevant conflict of interest. And the critical issues that Dr. Buchanan and Dr. McAvoy have highlighted, and that all of us have voted on and developed a consensus on, is the issue of sequencing. That was the guideline that Dr. Buchanan presented that we voted on a few minutes ago. What about dosing? What are the dosage ranges of these medications that are appropriate? How long should an antipsychotic trial be? We did not discuss that, but we'll talk. That's a relevant issue. If you try an antipsychotic for a day or 2 days or a week, is that an adequate trial? Or should, before you say something is not worked, should you have tried that medication for, say, 6 to 8 weeks? And finally, how are you tracking the benefits and risks of treatment? Talking about antipsychotics, we have 18 antipsychotics available here. They're classified into first generation and second generation agents. Now, clearly, these two are not homogeneous classes. There's significant heterogeneity across these classes. But since we use that particular terminology and have been using that, we have 11 first generation antipsychotics in the US. There are 51 available around the world. And we have 7 second generation antipsychotics available in our country. There are 11 available around the world. And iloperidone should be the 8th second generation antipsychotic that will soon be available in our country. So essentially, 11 first generation, 7 second generation antipsychotics. And there are 3 indicators that we currently have with regard to unusual antipsychotic practice, or an antipsychotic complex care indicator. That is, an indicator, when we review pharmacy claims, an indicator of unusual practice or less evidence-based practice that warrants closer scrutiny. Firstly, use of 2 or more antipsychotics for 60 or more days, and we're going to discuss as to whether that's a useful indicator. We need to modify it. Use of 3 or more antipsychotics for 60 or more days, and use of a high dose of an antipsychotic. The dose ranges are in the text, if you will, but we'll come to that when we review whether that indicator is or is not appropriate. What is antipsychotic polypharmacy? Use of 2 or more antipsychotics concurrently. That's what antipsychotic polypharmacy is. Some people refer to antipsychotic polypharmacy as adjunctive treatment, augmentation, add-on therapy, if you will, but it really refers to the use of 2 or more antipsychotics at one time. It's not unusual. It's very common. As Dr. McAvoy noted, about 30 to 60% of inpatients receive 2 or more antipsychotics at one time. And almost 5% of inpatients receive 3 or more antipsychotics at one time. 11 to 35% of outpatients receiving an antipsychotic receive 2 or more antipsychotics at one time. What about Florida? If one tracks the utilization of antipsychotics and antipsychotic polypharmacy in Florida's Medicaid program, it ranges between 15 to 20% over between 2002 to 2006. It's an interesting trend that we observe, that basically between 02 to 04, there was an increase from about 15 to 20% in antipsychotic polypharmacy. This program was introduced in December of 04. And since then, there has been a modest decline to about 16%. It's not gone down below the 15% where it started off in 02, but there has been a decline in antipsychotic polypharmacy from 04 to 06. Where do you see antipsychotic polypharmacy? You see a lot more in the context of conditions where antipsychotics have been approved for the treatment of that condition. About 25 to 30% of those with schizophrenia, schizoaffective disorder, have antipsychotic polypharmacy, in contrast to about 9 to 11% of those with other conditions. What's the rationale? The commonest rationale for antipsychotic polypharmacy is, well, I'm using medications that work best for this particular patient. Well, what's your specific reason for combining using two or more agents? Well, it works best for this particular patient. Well, how do you know it works best for this particular patient? Well, these are different medications. They have different properties, and I need to titrate the two medications precisely. There are many other reasons, as we will discuss, but that's the commonest. It's a loose explanation of why you're combining antipsychotics. Now, if one looks at the example of other classes of medications, where multiple medications in a single class are used for treatment of a condition, let's take a look at CNS conditions specifically, anticonvulsants. If one looks at combinations of two or more anticonvulsants for the treatment of a seizure disorder, what one finds is that the two anticonvulsants that you use have different mechanisms of action. You do not combine two anticonvulsants that have exactly the same mechanism of action. They have different mechanisms of action, and both those agents are used at therapeutic doses. Antidepressants, we don't combine two SSRIs. We combine two antidepressants with different mechanisms of action, again, using them at therapeutic doses. So if one thinks about polypharmacy in a given class of treatment for any CNS condition, what one finds is that these are the two broad principles: different mechanisms of action, you use them at therapeutic doses. Well, what about antipsychotics? As far as antipsychotics are concerned, all that we know in terms of pathophysiology is all of them have a little bit of that green, if you will. All of them block the dopamine 2 receptor. There is not a single antipsychotic that we have currently, none of the 62 antipsychotics available in the world, that do not block the D2 receptor. How potently, how weakly they block it, that varies. But essentially, all of them block the dopamine 2 receptor. Now, where all the 18 antipsychotics that we have in our country, and they don't neatly cluster into first and second generation antipsychotic agents, where they differ is in their profiles of blocking other receptors, various serotonin receptors, and in fact they stimulate they're partial agonists of the 1A receptor, things of that sort. So they have different properties. They all block the D2 receptor, but what else they do at different receptors varies. And that influences differences in their side effects. So if one thinks about titrating different antipsychotics to get it just right for this particular patient in front of me, well, in terms of efficacy, the only pharmacological property that is clearly linked to the effectiveness of antipsychotics, any antipsychotic, is blockade of the dopamine 2 receptor. All sorts of discussion about how much you must block it, what percent of D2 blockade you need, how persistently you need to block it, and things of that sort. But all the available antipsychotics work by blocking the D2 receptor. They differ in their other pharmacological properties, but we have absolutely no